All right. Welcome everyone to Lung Cancer Expo breakout session, Biocontainment and COVID-19 with our wonderful panel of doctors today. My name is Valerie Steinmetz and I am your American Lung Association moderator for this session. Just a few items before we hear from our speakers. Everyone in the room is muted with their video off. Please remain this way to ensure the highest quality call today. If you have any questions you'd like to ask of our presenters, please submit them in the chat feature throughout the session, and I will post the questions during the Q&A section of our call today. To access the chat feature, go to the bottom of your screen. In the black toolbar, find the icon that looks like a chat square labeled chat. Click on it and a chat window will appear. When submitting your questions, please submit them to me, and I will share these questions at the end of our presentation today. All right, it's my pleasure to introduce our first of three speakers for this session, Dr. Rudy Lackner. Dr. Lackner went to medical school at New York Medical College and did his residency at Long Island Jewish Medical Center. He did fellowships in cardiothoracic surgery at the University of Chicago and in heart and lung transplant at the University of North Carolina, Chapel Hill. He is currently the Vice Chief of Cardiothoracic Surgery and Chief of the Section of Thoracic Surgery. Dr. Lackner is also the Director of the Comprehensive Thoracic Oncology Program, as well as the Director of the Cardiothoracic Surgery Residency Program at the University of Nebraska Medical Center. He has a special interest in the combined use of surgery, chemotherapy, and radiation to treat advanced stages of cancer. He is very interested in the use of minimally invasive procedures in the treatment of these cancers. Dr. Lackner, thank you so much for your time and sharing your expertise with us today. The stage is all yours.
Thank you, Valerie. Just as we get started, I'd like to extend our thanks to Julia McCarville and to Megan Miller for first inviting us to participate in this program. And also for helping us kind of manage the logistics of all of that. It'd be tough to do without them. For this presentation, I don't have any disclosures. What I thought I would do is just, although I think the main part of what we'll be discussing here for the University of Nebraska will be in Dr. Hewlett and Dr. Johnson's talks, because this is a American Lung Association session. One of the other things that we do obviously have an interest in is lung cancer, and that has not gone away during the pandemic. And so what I thought I would do just for this brief presentation was just talk about some of the barriers that we've encountered in providing timely care to patients diagnosed with lung cancer during the pandemic, review some of the strategies that we've used to try and get patients through their treatments with all of these other things going on, and then kind of look at how we can kind of keep up our momentum with lung cancer screening during the pandemic. So as we all know, lung cancer is the #1 cause of cancer deaths. For 2020, it's estimated that about 228,000 men and women will die from lung cancer, and that is the #1 cause of death for both of those. The total lung cancer deaths represents about, excuse me, 22.4% of all cancer deaths. The good thing about that number is that it is decreased compared to where it has traditionally been, probably between 25 and 30% of all cancer deaths. And the other number, again, while low, is still a positive, is that the 5-year survival now for lung cancer has finally gotten up a little bit over 20%. For me, having done this for 25 years, it's taken 25 years to get us from about 14 to 15% to that 20% number, but at least finally it seems to be heading in the right direction. Worldwide, lung cancer will be responsible for about 1 million deaths overall. As we know, lung cancer does wind up highly impacting minorities, lower socioeconomic groups, and the elderly, as does the COVID virus. median age of diagnosis for lung cancer is now 70. And as has been discussed in many forums, there clearly is less advocacy and research funding for lung cancer compared to many other malignancies. Part of the problem we know is that lung cancer is curable, especially when it's detected at an early stage. However, our problem has been finding it before it is spread to lymph nodes or has become metastatic. And a lot of the progress that we've made has been in identifying lung cancers at an earlier stage. And so this is kind of, again, what we would like to see: solitary nodule in the lung without any lymph gland involvement nor any spread outside of the chest. So as with everyone around the country, we've obviously been dealing with this now for getting on close to a year. Certainly the spring, we saw the first wave of cases. And so not knowing what was going to wind up happening with the virus, we kind of went into a slowdown mode. So initially for us, what first happened is that we really cut back on the clinic volumes. We were able to see newly diagnosed patients with cancer, see patients who were immediately post-op coming back for follow-ups, and anybody who was having an issue that required immediate care. Problems were is that we really limited the number of people coming into the building, and so all the patients really would come into clinic without any family members present. So there was a lot of having the phone on speaker and trying to discuss especially new diagnosis and treatment without anyone there. Thoracic surgery, compared to most other procedures that are done in relation to the COVID virus, becomes a little bit more complicated to manage. All of the thoracic surgery patients routinely require a special double lumen endotracheal tube, which takes a little bit more expertise from the anesthesia staff to place. But in addition to placing it, it also requires a lot of bronchoscopy, which opens the system to make sure that the tube is placed, potentially during the operations to check position. So there is at least increased risk to staff during the course of the operation. So many of the barriers that we all have encountered with this is that, again, with the median age of 70, a lot of older patients are, very unwilling to wind up coming to clinic alone because they're afraid they're not going to ask the right questions or hear what we're telling them. And so they want somebody else there. Again, using the phones kind of winds up helping, but I think they kind of feel fairly alone for it. We did encounter a lot of patients who, once this was going on in Omaha, seemed to have more activity than outstate Nebraska. A lot of the patients were just unwilling to wind up leaving the house, not knowing how this was going to wind up unfolding. And then, again, trying to limit the number of people in the hospital. Initially, we had no family members allowed, so the patients would come to pre-op completely by themselves, have their operation, and then spend the duration of the hospitalization without anybody there. And so many of them, when they heard that no one was going to wind up being able to be there, elected to hold off until they could see how things were going to behave, and then hopefully be able to have somebody there. Certainly on, as we all remember, at the beginning, there was a lack of personal protective equipment, and so we were trying to maintain enough availability to care for the patients with COVID. And again, as the numbers seem to be increasing, there was redeployment of many of the clinic and even operating room staff to care for COVID. And so the normal routine for the operating room was changed around. Also, too, there was somewhat at the beginning the limited availability for COVID testing. And again, for those reasons, especially for thoracic patients, something that needed to be done. And so it took work to wind up doing that. Other things for our patient population for lung-related cases is that it got to be very difficult to wind up obtaining pulmonary function tests as many of the PFT labs either shut down or greatly reduced their capacity for doing it. And that is one of the things that we routinely get on anybody undergoing a thoracic surgical procedure. The operating room too then became a little bit more challenging, whereas normally most of us would have scheduled time to wind up doing our cases. The operating rooms went to more of a first come, first served type of situation. So the OR cases were prioritized, using kind of this letter designation from A to E, trying to fit the cases into what would wind up needing to go. So anything life-threatening that needed to go obviously needed to get done. Anything that was life or limb-threatening, kind of more urgent, needed to be done within 24 hours. Then the C designations were things that could wait probably up to about a month without affecting long-term outcomes. D cases were anything that theoretically could wait 4 to 12 weeks. And then the most elective of things were things that could wind up waiting more than 12 weeks. So a little bit of the dilemma is where exactly the lung cancer cases fit in this scheme. Clearly, the majority of these cases are not in the A and B grouping unless somebody was actively bleeding or having an emergent airway issue. But once you start talking to patients, as most of us would be fairly uncomfortable with delaying a lot of the treatment for these for greater than 4 weeks, there is at least data out there that looks at using time to treatment as a quality metric. In most of the studies, usually from time of diagnosis to treatment, ideally would wind up being under about 30 days, which kind of winds up putting us into that 4-week scheduling. But even with that, you can imagine the anxiety that that provokes in someone who's just been diagnosed with the lung cancer, and you're telling them, it may be a month or so until we can actually get you to the operating room. So the solutions that we found to try and manage this as an institution is that we work very closely with the operating room leadership to ensure that cancer cases were able to be scheduled in a timely fashion. And again, unless the patients, decided to wind up delaying it on their own, which fortunately was not too frequent, we could get things done in a little bit more timely fashion. Since a large portion of the patients that we operate here at the medical center come from hundreds of miles away in western Nebraska, we did have to wind up working very closely with the patients' local hospitals and with Nebraska Medicine Laboratories to try and get the COVID testing done in a timely fashion. And again, trying to get them so that they could get their preoperative pulmonary function testing, cardiac evaluation, and all of the other things that we would normally have done preoperatively so they could wind up coming. The other thing I think that made it a lot easier for a lot of the patients is that after the initial restrictions, negative patient feedback partly driving it, we finally were allowed to at least allow one family member to be present for the hospital stay. Still could not be present in the preoperative area or to be in the hospital while the patient was in the operating room. But once the patient left the recovery room and got to their room, then they were able to wind up being there in the room and then be there during their hospitalizations. Again, doing good precautions, wearing their masks, not leaving the room, eating meals in the room, and kind of not wandering through the hospital. For patients who've already been diagnosed and have had their treatments, obviously many of them were on regular schedules for their follow-ups, getting chest x-rays and CT scans done. Again, many kind of were okay with delaying things. What we try to wind up doing is so we didn't wind up getting off schedule, since we know that a lot of patients, if they're cancer is going to come back. It's usually within that first 12 to 24 month period. We didn't wind up getting too far off schedule. So for patients that were on the shorter follow-ups, meaning the 3-month ones, we would call them, make sure they weren't having any symptoms. Majority were very okay with coming in, getting whatever imaging done, and then we would review it. As long as it was not showing any evidence of progression, we'd call them, and then we would see them with their next follow-up visit. For the patients that were out a little bit farther, meaning for most of the lung cancer patients beyond 2 years, and same thing with the lung cancer screening patients. If they were on yearly ones, we didn't want to not see them for a couple of years. So we would have the scans done on schedule. And then once we were able to get them in, see them, but then we would schedule their next visit at a shorter physical interval, but a month, 12 months from their last scan. And now we would wind up staying on schedule. And with that, we were able to still service all of the patients that we were caring for. So our conclusions from all of this, I think, as everybody realizes, this is hugely stressful for everybody, for patients, family, and also for the staff. It's unbelievable to think about the amount of time that the staff winds up putting in, because you can imagine patients and their families are calling. They're told that things are not going to move along so quickly, having to schedule and coordinate all of the additional testing, all the additional COVID testing, just to try to get things done within the required timelines. I'm not exaggerating when I say that our staff is on the phone with the patients and their families from when they walk into the office until they wind up leaving. And usually most evenings they're not leaving until 6, 7 o'clock at night. So I think that we do need to continue to work aggressively with both patients that are just diagnosed with lung cancer, those who need lung cancer screening, because again, as the numbers on that first slide suggested, we have been making progress. Our survival has improved, and ideally we'd not like to see our numbers lose ground on all the progress that we've made. But again, we have to work in the context of what's going on globally at the institution. And as the number of COVID patients winds up increasing, this will continue to wind up being a work in progress. So I'll go ahead and finish there with that part of it related to lung cancer, and be happy to answer any questions. And then we'll get on to Dr. Hewlett and to Dr. Johnson.
Thank you, Dr. Lackner, for those insights in COVID response. Our final two speakers for this session are Dr. Angela Hewlett and Dr. Daniel Johnson, also with Nebraska Medicine. Dr. Hewlett is the Associate Professor of Infectious Diseases at the University of Nebraska Medical Center. She earned an MD from the University of Texas Medical Branch in Galveston, Texas, where she also completed a residency in internal medicine, served as chief resident, then completed a 2-year fellowship in infectious diseases, followed by a 1-year research fellowship and master's degree. Dr. Hewlett serves as Medical Director of the Nebraska Biocontainment Unit and currently directs the COVID-19 infectious diseases team at UNMC Nebraska Medicine. She has authored more than 95 publications and book chapters. Her textbook, Planning for Bioemergencies, A Guide to Healthcare Facilities, was released in 2018. She enjoys spending time with family, fishing, and traveling. Dr. Hewlett will share the virtual stage today with Dr. Johnson. Dr. Johnson graduated from the University of Michigan Medical School, then completed residency in anesthesiology and fellowship in critical care medicine at Massachusetts General Hospital. He was on the faculty of Harvard Medical School for 3 years prior to joining the Department of Anesthesiology at the University of Nebraska Medical Center. At UNMC, he is the Division Chief of Critical Care, the Medical Director of the Cardiovascular ICU, and the Associate Medical Director of the Nebraska Biocontainment Unit. During the 2014 Ebola outbreak, Dr. Johnson worked clinically and administratively as part of the Nebraska Biocontainment Unit leadership team to respond to the outbreak. More recently, Dr. Johnson is co-directing UNMC's critical care response to the COVID-19 pandemic and working in the COVID and non-COVID ICUs. His lecture will focus on pandemic planning and the response to COVID-19. Dr. Johnson enjoys spending time outdoors with his wife and children. Fun fact about our two doctors, they first started working together on September 5th, 2014, when Ebola came to Nebraska. Dr. Hewlett, Dr. Johnson, thank you both so much for being with us today. And without further ado, Dr. Hewlett, the virtual stage is yours.
All right, thank you very much, and thank you to the association for allowing us to speak today. So Dr. Johnson and I are going to tag team this presentation on biocontainment and COVID-19. We just really want to talk about kind of where we were in our biocontainment phase, which is a little bit historical, although it wasn't that long ago. It seems like it was forever ago. But then we'll progress and talk a little bit more about our transition from biocontainment into our mitigation phase, which is what we're in currently. So we don't have any relevant conflicts to disclose. So why Nebraska? I get asked this all the time. I'm originally from Texas, as you heard from my bio. This is my first real job when I finished my training in Texas and came up here to Nebraska. And why did I come here? Why were we, well, what's going on here? I guess I should say that allows for some of the facilities and that sort of thing that we have here at the Nebraska Medical Center, as well as throughout the state. So first of all, we're right in the middle of the United States. And the things you think of, and this is what I thought of when I first heard about this opportunity in Nebraska, you think about cornfields, you think about this is one of our unusual signs on the side of the road that I've actually come to appreciate quite a bit. But in actuality, Nebraska has some pretty interesting and unusual facilities. And one of those is the Nebraska Biocontainment Unit, which is located here on our campus at the University of Nebraska Medical Center. We opened in 2005. And we have a very unique facility here in that we're only one of several facilities within the United States that are actually with the sole purpose of providing care to patients with highly hazardous communicable diseases. You heard the mention of our care of our Ebola patients. We're actually set up to care for not only patients with viral hemorrhagic fevers like Ebola, but also other pathogens as well. Our facility is very unique. We have a separate air handling system, some other engineering controls like negative air pressure throughout our unit, HEPA filtration of all of our exhausted air. We have an in-unit laboratory, autoclaves for sterilization. We have an all-volunteer staff of physicians, nurses, respiratory therapists, patient care techs, and a lot of laboratorians and a lot of other people who essentially volunteer to come and to serve in the biocontainment unit to care for patients with the highly hazardous communicable diseases. We are one of the 3 lead institutions for the National Emerging Special Pathogens Training and Education Center, or NETEC. We are also the Special Pathogens Treatment Center for our Region 7 here in the United States. As was mentioned, we did activate the biocontainment unit to care for 3 patients diagnosed with Ebola virus disease in 2014, as well as multiple individuals who had high-risk exposures in Africa and were medically evacuated to be close to the biocontainment unit. Luckily, that none of those individuals became ill. We also did activate for COVID-19 in 2020, and that's what we'll talk about now. We also have the National Center for Health Security and Preparedness here on campus. This is a facility that actually is funded by the Office of the Assistant Secretary for Preparedness and Response, or ASPR. It is absolutely state-of-the-art training simulation center. We have some really innovative and unusual technology in the center for high-fidelity simulations. Within that building, though, we also have the National Quarantine Center, or the NQU, which actually opened in 2019, just in time for our care for our initial patients with COVID-19. This facility is secure access. There are 20 rooms. They have hotel-like amenities. It's a little bit sparse, so it's not your super fancy hotel, but it's comfortable. There are exercise equipment in every room. We have negative pressure throughout the facility, and this was essentially designed to quarantine individuals who have been exposed to highly hazardous communicable diseases. But we actually had to use this facility fairly quickly. And if some of you remember in the news, some of the initial COVID patients in the United States were brought to Nebraska. They actually were from a cruise ship called the Diamond Princess, which had departed Japan and had a lot of passengers on board, 3,700 passengers and crew. In late January, there was an individual that became ill. And if you remember what was going on in January, although, COVID was out there, this was not something, these folks went on a nice cruise out in Japan with a lot of other people, but fairly quickly, they came to realize that there were some individuals on the cruise ship that were sick. We actually received our request from the Assistant Secretary for Preparedness and Response, and we actually sent one of our physicians, Dr. James Lawler, departed Omaha en route to Japan to assist with the operations on the Diamond Princess cruise ship. And on February 17th, there was a repatriation flight that landed in Omaha with 15 Americans on board. At that point, we clinically assessed the individuals on the ground right after they got off the plane. There were 13 that had confirmed COVID-19 at the time and 2 that were negative but had high-risk exposures. We also had, some patients that were asymptomatic and some that had mild symptoms, and those individuals were actually sent to the quarantine unit for monitoring. However, we also had one individual that did require immediate hospitalization in the biocontainment unit. And during their stay with us, eventually 4 of our patients did require hospitalization in the biocontainment unit due to a variety of different things, hypoxia, arrhythmia, neurologic problems, several other issues, but actually all recovered. And you can see some of the photos here of our operations. So just some clinical and operational challenges that we, this was early. This was a very early in the pandemic. Not a lot was known really about anything. This was a very rapidly evolving situation, and there were changes in guidance occurring daily, if not hourly. You could make a case that that's still going on, and that we still, we're still experiencing that now with the rapid changes that are occurring with our therapeutics and vaccines and, all sorts of guidance. But, there were lots of hot topics at that time that essentially had little or no scientific backing whatsoever. Should you take non-steroidal anti-inflammatory meds? Were they harmful? Were they helpful? What type of therapeutics should we use? What type of personal protective equipment? There were a lot of unknowns at the time. The diagnosis and testing process was actually very problematic, just due to the unavailability, for the most part, of a lot of tests, although our laboratorians here did an absolutely stellar job of creating and quickly getting approved an in-house test. And so we were able to have some testing capacity here, which we were very thankful for. But we didn't know much about the sensitivity, specificity of these tests. There wasn't a lot of clinical information out there, particularly on mild or asymptomatic infections. People really weren't talking about asymptomatic infections at the time. And also some of the complications that we know to be true now were really not anything that was known at that point. And there really wasn't anything potential therapeutic agent-wise. There were also a lot of issues with hospital discharge planning for our patients, mainly because we didn't know when isolation could be discontinued. Typically, the individual shed virus, or at least had a positive PCR for a long period of time, but no one really understood what that meant. And so clinical lessons learned, our patients, some became critically ill and required hospitalization. Sometimes this could happen fairly quickly. Actually, patients could be relatively well one moment and then decompensate very quickly. We did have several of our patients who had arrhythmias, which were either worsening of a known condition or totally new. And there really wasn't much known at the time about cardiac manifestations of COVID-19. We also saw some issues with pre-existing neurologic conditions that became worse. We also our patients experienced the loss of smell and taste, which was sort of interesting because that had not been linked at all to COVID-19 at the time. And in actuality, we thought they just didn't like the hospital food at the time. The patients were complaining about not being able to taste and smell, and the food tasted bad and that sort of thing. But again, that was something that was totally unknown at the time. We did see that prolonged viral shedding via PCR, but didn't know a whole lot about what to do with that. And so staffing-wise, operationally, this was definitely a challenge. Our amount of staff that we needed to care for these patients definitely exceeded our initial plans. There were a lot of issues with infection control and employee health processes regarding personal protective equipment. There was a lot of debate using PAPRs, which is what we had typically used in our biocontainment unit, versus more of an N95 face shield protective equipment, when to discontinue isolation, when and if to screen healthcare workers who are working directly with patients. And then we also learned a lot about research, about facilitating research for COVID-19. We were actually the first study site for the treatment trial, COVID-19 treatment trial, our Act 1 trial. And our first patient in the United States was actually one of our Diamond Princess patients. So we learned a lot about those processes and how to facilitate research regarding COVID-19. We also learned very quickly that quarantine and isolation are very difficult and frightening for patients. And this is something that we really tried to do our best to counteract by having daily town hall meetings with our Diamond Princess patients. We involved the patients, our nursing staff, behavioral health, our physicians, and really tried to kind of talk out some of the concerns. But you have to think about, this set of patients were, again, individuals who went on a really nice cruise ship and ended up in the middle of Nebraska in isolation in a facility. And so we did our best to try to counteract some of those issues, but they definitely are significant. And just to kind of segue into our transition from biocontainment to mitigation, initially, our patients were all cared for by our biocontainment team, whether those were our nurses or physicians or respiratory therapists or others. We now have employed a large number of individuals to care for our COVID patients as we entered that mitigation phase. And so currently, our hospital medicine teams, critical care teams serve as those primary teams in our COVID units. And they essentially manage the majority of patients in the units. But since then, with our surge, we've had to also employ several other primary teams to assume care of our patients due to our current and ongoing surge. We do have a COVID infectious diseases team that actually we started back in March, kind of early on when we switched into our mitigation phase. That team actually reviews all new admissions to the COVID units. We assist the primary teams, emergency department, and others with testing decisions, some of the difficult decision-making regarding patients under investigation and best screening for those individuals, one test versus two tests, where to test from, things like that. We also assist with clinical management of the COVID patients and make sure that we are documenting how long patients need require isolation, answering lots of questions regarding infection control. We work with essentially a variety of other groups to help create those clinical and operational protocols within the COVID units. And with that, I'm going to turn it over to my colleague, Dr. Dan Johnson, who's going to talk a little bit about our evolution from our biocontainment phase to mitigation. Dr. Johnson.
Thank you very much, Angela, and I'd like to thank the American Lung Association for inviting us to speak today about a topic near and dear to everyone's heart these days, COVID-19. Next slide, please. So there's been a lot of talk about playbooks, both federal level, state level. I can tell you that at UNMC, we did have a playbook, a very detailed playbook for what to do in a circumstance like this. And I should give credit, it's probably too small to see, but Shelley Schwedhelm is our director here for preparedness. And this was really her baby. Go ahead and next slide, please. So she started to develop this 92-page playbook back in 2005 during an H5N1 avian influenza outbreak. And you can see the level of detail that we have in this playbook. And it started smaller, it's gotten bigger over the years, more and more detail has been added. But I want to point out on the right-hand side of the slide there that these committees were put into place back when they created this playbook, and these committees have members identified. So these aren't like a framework of people that you would need. These are people who actually know that they are on, say, the research committee for a pandemic situation. So I thought that was very helpful going into this when we switched gears from biocontainment over to mitigation. Next slide, please. So this is our friend and colleague, Dr. James Lawler. And I remember distinctly when I was sitting next to him, probably too close to him, back on February 26, 2020. We had just heard the news that in Sacramento, California, public health officials announced that there was the first known case of community spread in the United States. So this meant that someone had contracted COVID-19, but they did not have a direct contact that they knew had COVID-19, and they had not traveled. So what he uttered kind of under his breath was, well, here we go. And that really unsettled me because James Lawler is one of our nation's best experts on pandemic response. And I could tell by the tone in his voice that he thought our country was about to get absolutely rocked, and obviously he was correct. Next slide, please. I was walking through the hallways next to our operating rooms one morning when my friend, Dr. Nick Markin, pulled me aside. And he said, Dan, did you see the slide that James Lawler presented to the American Hospital Association yesterday? And I said, no, what was it? And I had heard James talking about the pandemic already, but I hadn't seen this slide. And the thing that really caught my attention was the lower right there, where it says 480,000 deaths. Now, keep in mind, back in February, almost no one thought the United States was going to have anything close to 200,000, 300,000 deaths. Well, we now have surpassed 280,000 deaths in our country, and it's not slowing down, it's actually speeding up. And so this number that James sort of estimated using mathematics and his background in epidemiology is looking more and more realistic, sadly. Next slide, please. I remember distinctly when we admitted our first COVID-19 patient, we transferred them from community hospital here in Omaha over to our university hospital to put her in the biocontainment unit. So what I mean by this is the first citizen of Nebraska that contracted the disease and was admitted to our hospital. Obviously, we had taken care of the Diamond Princess cohort prior to this. Next slide, please. Every day at 9 a.m. At the beginning of the pandemic, we had a statewide community briefing, and James would do a 10-minute presentation on where we were. And his presentation on March 6th read, COVID-19 is everywhere. Seattle, rapid growth, 2 more skilled nursing facility outbreaks. Social distancing is increasing. Stanford and UW canceled classes. CDC testing is backlogged. There's a cruise ship off of San Francisco, California, which might result in calls to Nebraska for isolation. And then he said, prepare for community transmission. The Nebraska Biocontainment Unit is not designed for what we are about to endure. That was chilling when he said that. Next slide, please. So we realized that we needed to switch gears from quarantine and biocontainment to mitigation. Initially, all of the hospitals in our region thought that all COVID patients were going to come to our hospital. We'd kind of become famous for this biocontainment stuff after Ebola, and we had to work hard to get the message out that it wasn't just going to be the biocontainment unit, it was going to be the whole hospital. And it wasn't just going to be us. We needed every hospital in Omaha and every hospital in the state of Nebraska, the state of Iowa, South Dakota. Every hospital was going to need to pitch in during a pandemic. So a lot of the leaders of the biocontainment unit worked really hard, both in the hospital and outside of the hospital, to make sure that people were ready. And I think we used our time really wisely there before we got really hit hard in April and May. We used the month of March to really make sure that our hospital was prepared with all of these different facets. Next slide, please. So if you think about it, on March 7th, we had 20 doctors looking after 1 patient in the biocontainment unit. We literally would get on a conference call and go through every single detail on that 1 patient because we wanted to will her to survival. And we did. Then by May 7th, we had 1 doctor looking after 20 COVID ICU patients. So that kind of gives you a sense for how quickly things changed for us. Next slide, please. So this is from US NIOSH, and this is the hierarchy of controls. How do we respond to a hazard in the workplace? And you can see that the best thing to do, the most effective, is to physically remove the hazard. So I guess you could say that our cleaning protocols, we're removing SARS-CoV-2 from our workplace the best we can. We can't really substitute anything for SARS-CoV-2. Engineering controls we definitely used, and we'll talk more about those. Administrative controls we definitely used a lot of, and we'll talk about that. And then, of course, everyone's favorite topic for the year 2020, personal protective equipment. Next slide, please. So what are some of the things we did for engineering controls? Well, we converted one of our 4 main bed towers into basically every unit being negative airflow. So our university tower went from having lots and lots of different missions to essentially being a COVID tower. We would open the next unit based on 80% capacity. So for example, we had a COVID ICU on the 7th floor, and we didn't open the next COVID ICU until we hit 80% capacity in that floor, and so on and so forth. Same thing for the med-surg beds. We increased our ICU capability from 92 to 178, and we increased the overall capacity for beds in our hospital from 597 to 753. Just by the grace of God, we had already approved money to buy an entirely new fleet of ventilators. in the year 2021. So a bunch of intensivists called the hospital leadership and said, we know that capital has already been approved. Let's get those vents here now, just in case we need them. So we went ahead and just about doubled the number of ventilators that we have. Next slide, please. Here you can see the ductwork that we had installed in one of our large bed units, converting this from a normal airflow unit to a negative airflow unit. And I want to give a lot of credit to the hospital leadership, because they spent the money and took the trouble to get contractors into our hospital. And the contractors worked 24/7 in the spring to get this ductwork in, which made the care of these patients safer for healthcare workers. Next slide, please. So we've already talked a little bit about the PPE that was used early on when we were using the biocontainment unit for all of these patients. You can see that on the left. You can see on the right here our standard PPE for COVID-19 patients, which is very similar throughout the United States, I think, at this point. We use reusable gowns, we use disposable gloves, face shields, and N95s for direct patient care. Obviously, this has changed a lot. I can tell you that by, I'd say, early April, we were using the PPE there on the right. And one of the happiest moments of my life was when we got through April, we got through May, and I said, wow, we've been doing this for a lot of patients for 2 whole months. So I called the head of nursing and I said, are there any RNs from the COVID ICU who have gotten sick? And she said, 0. And I said, so then I called the head of respiratory therapy and I said, Darcy, have we had any respiratory therapists get sick with COVID-19? She said 0. And I thought, oh my gosh, this is amazing. This PPE definitely works. At that point, we had thousands of contact hours between healthcare workers and patients. And that was the #1 question going into this for people like Dr. Hewlett and I, and her boss, Dr. Rupp, who's in charge of infection control. Is our PPE going to work, and how many healthcare workers are going to get sick? So we know that when this is properly used, it absolutely does work. Next slide, please. So we had to start thinking outside the box, because as you will recall, across the country, there was going to be a huge shortage of N95s and other PPE that are essential for the care of this disease. So some brilliant people that Dr. Hewlett and I work with, Dr. John Lowe, Dr. Mark Rupp, and some others, concocted this system where you expose used N95s to UV light and it eliminates the virus. So they scientifically proved that the virus was no longer present after this treatment, which allowed each individual user to have an N95 get decontaminated over and over and over again. And this is still the process that we use. And so it saved us thousands of N95s over the course of the pandemic. We had surgical drapes that we had people sew them into masks to create more masks, both for healthcare workers, but also for our visitors. We were running low on swabs for testing. So people used 3D printers to create new swabs. They weren't quite as comfortable as the regular swabs, but they worked and we needed them. Most places are using pooling of tests these days. Some of the people that invented that concept work right in our backyard here at the Nebraska Public Health Lab and at the Nebraska Medicine Chemistry Lab. That's taking a pool of low likely positive tests, putting them, running maybe 10 together. If the test comes back negative, all 10 of those are negative, and then you've just used 1 kit instead of 10 kits. We had a lot of different PAPRs here for high risk procedures, but they didn't talk, all the PAPRs didn't talk to all the motors. The hoods didn't talk to all the motors, so we 3D printed different adapters so that we could interchangeably use hoods and PAPR motors. And then we'll talk, and then there's a device that we created where it's the infectious agent. It basically suctions away viral particles over the patient's mouth to try to keep the room safer. Next slide, please. So people like Dr. Hewlett and I have spent a good deal of our time over the last 9 months trying to sound the alarm. At different times in the pandemic, people in Omaha, people in Nebraska, people across the country just didn't appreciate the magnitude of the risk. So we have taken to traditional media, social media, any way we can get the word out to try to alert people when it's a really high risk situation. So when this slide was made, Douglas County was 4th in the country for new cases per million per day. Douglas County is the county where Omaha is. Unfortunately, we have now made our way up to number 3 on this list. I just checked yesterday afternoon. And so, you know, I'm often telling family and friends, there is no safe place to be indoors with people from outside your household. I can honestly tell you, my wife and kids and I have not been indoors with anybody from outside our household for any non-essential activity since March 7th. And that's been difficult, but that's the right behavior when you're in the middle of a deadly pandemic. Next slide, please. So we're also trying to watch and warn people in our state. You can see here, this is from several days ago. We had an absolutely horrific rise in the number of hospitalized patients here. That curve there at the lower right of the blue section was extremely bothersome to those of us who care for these patients in the hospital. We were screaming from the rooftops, basically, to tell people in Nebraska how dangerous this was and the risk that we could potentially overwhelm our healthcare system. You can see that we've had a dip in our daily active hospitalizations. So we've been a little bit less strained the last week or so, but I can tell you our case rate is still extremely high. And every time you have a really high case rate, you're going to have a really high hospitalization rate a few weeks later. So we're just sort of bracing for what's coming. And I still am concerned that hospitals in Omaha and throughout Nebraska can become overwhelmed. Go ahead, next slide. So every morning I have a morbid ritual where I go through about 6 different sources of data to give myself a sense for how bad things are. And the morning I woke up and realized that COVID Act Now had to invent a new color in order to describe how bad the situation was in the middle of America, my heart sank. So red used to be as hot as you could get on these COVID maps. Well, now COVID Act Now has invented the maroon color to show that there's a severe outbreak. And look at how many states, when I made this slide, were maroon. I think it's slightly better now, but not much. Next slide, please. I know that everybody's sick and tired of hearing doctors and politicians and our cute little catchphrases for how to not get COVID-19, but think about this. The Japanese came up with the 3 C's very early on in the pandemic, and by and large, the nation of Japan has done fairly well with their COVID-19 outbreaks, certainly in comparison to the United States. These 6 things that I'm about to say, if you do all 6 of them, you literally almost cannot get COVID-19. And they're very simple. So you avoid closed spaces with poor ventilation, you avoid crowded places with many people nearby, avoid close contact settings such as close range conversations, you wear a mask, you watch your distance, and you wash your hands. These are not difficult things to do. This virus is not difficult to defeat. We have simply not done these 6 things. And we can turn it around. There's nothing about a viral outbreak that is irreversible if human beings simply don't get together for several months. We get lots of people vaccinated. We can get this thing turned back around, and I think we will get it turned around. Next slide, please. So anybody who's gone fishing with a small child knows what this guy's going through. Some people, including myself, particularly several months ago, kind of felt like this was what 2020 was all about. I feel new optimism in December that I haven't felt in a really, really long time. There was no guarantee that vaccines would be effective and safe. I believed in my heart of hearts that human beings, being the intelligent life forms that we are, that we would figure it out. But the fact that these brilliant scientists have figured out 2, 3, maybe more effective, safe vaccines, that is absolutely great news. Now, for everybody on the Zoom today, I want to encourage you to reach out to 10 people and talk to them about the importance of getting a vaccine. If there is a safe and effective vaccine, people need to use it. It is even more important than the flu vaccine is. And you hear how much we harp on the flu vaccine every year. This one is even more important, and it's more efficacious. So I really, really want to encourage that. And I think that's the end. Just check and see if there's another slide. Oh, yes. I want to say thank you to all of our team members here at Nebraska Medicine, UNMC, and particularly at the Global Center for Health Security. Our colleagues there have literally worked just about every single day since this started to make sure that we try to get this thing turned in the right direction. Thank you very much.
Wonderful. Thank you, Dr. Johnson, Dr. Hewlett, and Dr. Lackner. We sincerely appreciate you taking time to share with us about your experience today in working with COVID during the COVID pandemic, but also prior pandemics as well. And sincerely appreciate the work that you continue to do in your communities to keep us safe. I just want to remind participants that we are now going to head into a 5-minute break. We have a few minutes left in our session today, so if anyone has any questions they would like to ask of our doctors while we still have them, please write them in the chat box and I will share those with our speakers today. But otherwise, we'll head into a 5-minute break. And the next round of breakout sessions will begin at 2 p.m. Eastern Time. And please remember to head back into the 6 Connects virtual lobby to access the next set of session access links and to complete the session evaluation located in the agenda. And it looks like we do have one question that came in. Is it dangerous to gather with social distance outdoors right now?
Angela, do you want to start?
Sure, I can start, and yeah, feel free to jump in. Yeah, so that's a great question. We've always, and we understand that indoors versus outdoors, there is a very significant difference between those two spaces, just in the ventilation and the fact that when you're indoors, you're really stuck in there, and particularly in indoor spaces that are small or have inadequate ventilation, that just really allows this virus to, it's just easy to pass this virus from person to person when you're in those closed spaces. Outdoors are different. You've got wind currents, you've got a lot of dispersion going on. That being said, it's not that this virus can't be transmitted outdoors. And so the way that I look at this is that if you have a significant social distance, if you're on a walk in your neighborhood and the closest person that you see is like way across the street from you or that sort of thing, then no, you don't need to wear a mask. You're socially distanced. That virus is not going to, to a significant amount of virus outdoors is not going to travel, 20, 30 feet, that sort of thing. Can you sit around in your backyard with a bunch of other people? Probably not. The way I look at that is that if you're in close contact, just understand that although we preach the 6-foot rule, that is really a minimum, and that that virus definitely, smaller particles can definitely travel further than 6 feet. And so if you're having prolonged contact with someone and you're relatively close together, then I still would wear masks in that situation. So it just depends on the scenario. Outdoors, definitely safer than inside, and we would choose that any day of the week. Still just be careful about keeping that distance and making sure that you're not in a crowded environment.
Yeah, I would agree with everything Dr. Hewlett said. Just in general, I think people have, because they've been given misinformation, they think that being outdoors is magical, that like, oh, as long as you're outdoors, you can do anything you want. But we all know that if you're talking to somebody 2 feet away and you're outdoors, they can clearly get droplets from their mouth into your nose and mouth. The fewer people, the better. The farther apart you are, the better. When it's breezy, I feel safer when it's breezy than when it's still. But outdoors, you still need to socially distance. So like, I like to golf, but I didn't share a golf cart with anybody ever since this started. It was just my wife and kids and I would be on a golf cart, but nobody else was allowed to share a golf cart with me. So if I golfed with other people, I would take my own cart or carry my own clubs, and I would stay like 10, 12 feet away from people all the time, especially when the rates are as high as they are right now. A good rule of thumb right now is to assume that every human being that you see has COVID-19. Honestly, and I operate that way. I have to go on clinical rounds with a team of 12 people, and I remind people all day, everybody step away from each other a little bit. We have masks on, but I mean, I bet 2 or 3 people on my team have it right now and they don't even know it. I have healthy young residents and med students on my team. A lot of them are unfortunately getting together outside of work. And so I just assume every person I see has COVID-19 and I conduct myself accordingly. For more essential things like seeing grandparents. So what we do is I just have my mom and dad sit on lawn chairs about 15 feet away from us, and we sit 15 feet away from them. My kids don't get anywhere near them. We don't get anywhere near them. We sit outdoors. We'll talk for 30, 45 minutes, and then that's that. That way we can still see each other and not have relationships break down. But that's about the extent of what we do.
Thank you. We have 2 more questions I'd love to get to in this next 1 minute, if you guys can hang in there. So if you get vaccinated, can you still be a carrier?
I can start with that. Yeah, so that's actually a great question, and one that we don't know enough yet about that to say definitively. You know, we know that the vaccine seems to protect people from getting severe disease in particular, but we don't really understand if that means that you're not acquiring the virus at all and just having still being able to shed the virus, but having a milder case, or you know, that sort of thing, where you don't go on to need hospitalization or critical care. We don't really understand that yet, and so that's something that just because you're vaccinated doesn't necessarily mean that you can't acquire this virus and shed it. What it does seem to mean is that even if you do acquire the virus, that it doesn't translate into severe illness, which is actually still a very significant achievement, just in the fact that, as Dr. Johnson mentioned, I mean, if we have a vaccine that's 95% efficacious, that's way more than any of us had ever hoped. And I agree with him that I'm feeling more optimism in December than I have for a really long time based on that vaccine. But the question is, you know, what I hear a lot is, if you get the vaccine, does that mean you don't need a mask anymore? And the answer to that is no. Because we don't know, could you still acquire the illness and potentially shed it, you know, and transmit to other. So the mask and things are not going to go away anytime soon.
Thank you. And our last question, you mentioned reusable gowns were used. Were the gowns changed between patients, and why reusable?
The reusable nature of those gowns is because if we would have used disposable gowns, we would have run out of disposable gowns about April 15th. So you remember the whole country was trying to get their hands on PPE. And so, those reusable gowns are water impervious. They're designed for infection control. And we had a lot of them. And obviously taking them off, washing them, and reusing them is much, much better use of resources than trying to buy millions of disposable gowns, not to mention the impact on the environment, of course. Yes, in between patients, they get taken off, put into a hamper, hand hygiene, our face shields get cleaned, and then when you go into another patient's room, you don a new gown. And so in order to manage all that laundry and all those gowns, we had nurses from other parts of nurses and other healthcare workers from other parts of the organization repurposed solely to untie knots, fold gowns, roll them up, put them back in the places where we could pick them up to don a new gown. And it was really cool to see. You had like outpatient surgery center nurses there, you know, undoing the knots on the gowns to make sure that we had enough gowns when we were really surging. And that's probably, I don't know that that's going on as much in the fall as it did in the spring, but I just remember seeing people from all over the organization chipping in and being used for different roles.
Well, thank you all so much again, our participants and our doctors, for hanging in there with us for an extra few minutes today. We sincerely appreciate it. So that will end our session for the day, and we'll see you at the next breakout session. Thank you, everyone.
Thank you.
Thank you, Valerie.